Vanakkam. When we want to talk about wrist block, we need to know the following things. First, what is the wrist block and what does it do? Second, why do we need to give a wrist block when you can always give a digital block for a small finger injury or an axillary block or an interscalene block for a major injury on the hand? Third, when do we give this block? In other words, the indications for a wrist block in hand surgery. Fourth, where do we give the wrist block? That is, the surface markings. And finally, how is the wrist block given? That is, the technique of giving the wrist block. We shall see all this, and we shall also see the salient features associated with giving a wrist block for hand surgery procedures. We shall learn about the wrist block anesthesia under the following headings: relevant anatomy, the surface anatomy, indications for wrist block, the drugs that we are going to use, the actual technique of giving the block, and salient points to remember when giving a wrist block. Since wrist block involves blocking the sensory nerves of the hand, we shall see the relevant anatomy. The sensation on the hand is supplied by the median nerve, the ulnar nerve, the dorsal sensory branch of the ulnar nerve, and the superficial branch of the radial nerve. The ulnar nerve, through its superficial branch, supplies the ulnar side of the palm of the hand, the ulnar side of the ring finger, and the volar aspect of the little finger, along with the dorsal aspect of the terminal phalangeal regions of the two fingers. The median nerve supplies the radial 2/3 of the palm of the hand, the volar aspect of the thumb, the volar aspect of the index and mid fingers, and the radial aspect of the ring finger. It also supplies the terminal phalangeal region on the dorsal aspect of the index, mid finger and thumb. The superficial branch of the radial nerve supplies the dorsal aspect of the hand on the radial 2/3 and supplies the proximal phalangeal and middle phalangeal regions of the index finger, mid finger, ring finger and the proximal phalangeal region of the thumb. The dorsal cutaneous branch of the ulnar nerve supplies the ulnar 1/3 on the dorsum of the hand and the dorsum of the little finger and ulnar border of the ring finger. So how do we identify these nerves that provide sensation on the entire hand? The patient is asked to oppose the thumb to the little finger and forcibly flex the wrist joint. When this is done, the palmaris longus and the flexor carpi radialis tendons will stand out prominently. Just deep to the space between these two tendons, about 3 to 4 centimeters proximal to the wrist, is the point where the median nerve will be blocked in the wrist block. When forcible flexion and ulnar deviation of the wrist is done, the flexor carpi ulnaris tendon can be palpated on the ulnar border of forearm. The ulnar nerve lies deep to this tendon along with the ulnar artery and can be approached either from the medial side or lateral side of the tendon. The dorsal cutaneous branch of the ulnar nerve supplies the dorsal aspect of the hand by passing subcutaneously under the skin between the ulnar styloid and the medial aspect of the flexor carpi ulnaris tendon at the level of the wrist. The superficial branch of the radial nerve lies subcutaneously over the radial border of the lower end of the forearm at the level of the wrist. Before seeing the technique of how to block these sensory nerves, we shall see the indications for the wrist block. Though the wrist block can be given for the management of multiple finger injuries, it is advisable to give an axillary block or a supraclavicular block for such injuries as the time needed for the reconstruction may be more. The first ideal indication for a wrist block is joint arthrolysis, done in cases of proximal interphalangeal joint stiffness of the fingers with little joint space not responding to therapy. In these conditions, the joint has to be released and at the same time the active movements must be tested on the table. Similarly, when there are adhesions after flexor tendon repair, the full passive range of movement is present and the active range is limited. We need to release these adhesions and we also need to test intraoperatively the range of active motion that has been achieved. Having decided to give a wrist block, we now need to see what are the drugs we are going to use for blocking all these nerves. To give the complete wrist block, we shall be mainly using three components: 2% lignocaine without adrenaline, 0.5% bupivacaine, and distilled water. For blocking of the median nerve, we require 3 ml of each of these solutions. For blocking the main ulnar nerve, we need 2 ml of each of these solutions, and the same amount of solution for blocking the superficial branch of the radial nerve and the dorsal cutaneous branch of the ulnar nerve. These volumes mentioned here are for an average adult weighing about 60 kilograms. So even for a complete wrist block, we will be using 9 ml of 2% lignocaine without adrenaline, 9 ml of 0.5% bupivacaine, and 9 ml of distilled water, which is well within the safe range. Now we shall see the technique of giving the wrist block for the median nerve, the ulnar nerve, the superficial branch of the radial nerve, and the dorsal cutaneous branch of the ulnar nerve. First, the median nerve block. Under aseptic technique, after informing the patient, the flexor carpi radialis and palmaris longus tendons are marked as already described, and a point in this space between the tendons about 3 cm proximal to the wrist crease is also marked. 9 ml of anesthetic solution is loaded as described. The needle enters the designated point at 45-degree angle and advanced to hit the bone. It is then withdrawn for about 2 mm, and after aspirating and making sure it is not in a blood vessel, the injection is made. There is another technique in which the median nerve block can be achieved. Just at the level of the wrist crease, the needle is inserted at 45 degrees and the tip of the needle should point towards the metacarpophalangeal joint of the middle finger. In this way, the needle is actually entering into the carpal tunnel under the flexor retinaculum. After the needle is inserted, we should make sure that there is no movement of any of the fingers, in which case it would mean that the needle is inserted into the tendons that are also a component of the carpal tunnel. Now the drug is injected very slowly and there should be absolutely no resistance to this injection, and this would mean that the tip of the needle is well within the free space of the carpal tunnel. While injecting, we might feel a fullness that occurs in the palm distal to the flexor retinaculum. Now for the technique of giving the ulnar nerve block. The flexor carpi ulnaris tendon is marked as already been described, and the injection needs to be made about 3 cm proximal to the wrist crease, either on the radial side or ulnar side of the marked flexor carpi ulnaris tendon. In this video, the injection being made from the radial side of the FCU tendon is being demonstrated. The needle is inserted at the point marked and the needle goes deep to the flexor carpi ulnaris tendon for about a centimeter. After that, aspiration is done to make sure that the needle tip is not either in the ulnar artery or the vena comitans, and the injection of about 6 ml of the solution that has been prepared is made. Now for the technique of blocking the superficial branch of the radial nerve. The surface marking of the superficial branch of the radial nerve is made as has already been described, and a subcutaneous cuff of the drug is going to be deposited in this area. About 6 ml of the solution is prepared and the injection is made after pinching up the skin on this area. Aspiration must be done to avoid injecting into the cephalic vein, and the drug is injected over the area that has been designated. Finally, the dorsal cutaneous branch of the ulnar nerve is blocked by injecting a subcutaneous cuff in the area that has already been described, that is, between the ulnar border of the flexor carpi ulnaris tendon and the ulnar styloid. About 6 ml of the solution is injected in this area. Though we have seen the exact technique of giving the wrist block, there are certain salient points to remember when giving the block. The first important point is that we need to wait for a minimum of 10 minutes for the block to take effect. The second is If you are planning to use a tourniquet for the surgery being done under wrist block, the tourniquet must be released within 15 minutes. Beyond 15 minutes, the patient will start experiencing pain, and this should not be allowed. If you feel that you may need the tourniquet for a longer period of time, the planned surgery should not be done under wrist block, or if the surgery has already been started, it is then better to give either supraclavicular block also or convert to general anesthesia. Here we need to remember the advantages of giving a wrist block. The most important advantage is that the patient can actively mobilize the fingers as he is conscious, and there is no motor blockade except of the small muscles of the hand. Hence, this type of regional block is ideal for flexor tendon tenolysis, PIP joint arthrolysis, finger metacarpophalangeal joint arthrolysis, as the excursion range of the flexor tendon can be assessed on the table. And the additional advantage of the wrist block is that a catheter can be applied, especially for the blockage of the median nerve, and this can help in giving post-operative anesthesia for continued mobilization of the fingers. The venous cannula can be inserted as done for the median nerve blockade, and about 4 ml of 0.25% bupivacaine can be injected every 8 hours through this cannula and fixed with an elastoplaster. It is very important to inform the patient and the staff nurse that no other injection should be made into this cannula. Now let us see an example of a surgery being done under wrist block. This patient has had an injury 1.5 years earlier with an attempted surgical correction of the unreduced dislocation of the proximal interphalangeal joint. However, there is no movement, either passive or active, at the level of the proximal interphalangeal joint of the little finger. X-ray shows loss of the articular surfaces of both the proximal phalanx and the middle phalanx, and a very narrow space between the two bones. The full range of active flexion at the distal interphalangeal joint is available. Hence, this patient needs a release of the proximal interphalangeal joint and a tenolysis. This would be ideal under wrist block anesthesia. Under wrist block, after an exposure by making a neutraline incision, the PIP joint has been released and flexor tenolysis has been done. Now the patient can be asked to flex the entire finger, and the active range of movement can be tested on the table. Once it is confirmed that both the passive and active range have been achieved at the PIP joint, the skin can be closed and the patient can be asked to continue the mobilization to demonstrate full range of movement, which can be shown to the patient himself. This would serve as an incentive for the mobilization later, and this is the advantage of using the wrist block in such surgeries so that we can get good results. I hope you liked the video. I enjoyed making it. Please click on the shown links to see more about other basic procedures in hand surgery like the digital block. And do not forget to subscribe to keep connected with the latest in learning hand surgery.